this video, I'm going to tell you about this ECG. If you see the lead 2 strip here, let us count the distance between two RR intervals. Here it is approximately 2 boxes. Here it is one box, approximately 2 boxes. Even if you take 2 boxes, that is to count the heart rate, the formula is 300 divided by the number of large boxes. So here the number of large boxes is 1. Here if you can see, this is 1 or 1.5 something. Here 1, 1.5. So even with 2, it is 150, which is more than 100. So this says it is tachycardia. And if you carefully see the QRX complexes, it is occupying one small box. Here also it is occupying one small box. Here one, like that. So QRX complex also it is occupying less than 3 small boxes. Whenever QRX complex occupies less than 3 small boxes, then it is called narrow QRX complex. If it is to be told in the seconds, one small box is 0.04 seconds. Here 3 means it is 0.12 seconds. When it is less than 0.12 seconds, then it is called narrow QRS complex. And if you see the P wave, it is not properly seen. Here the P waves are hidden in the T wave. So the ECG tells us that there is absence P wave and there is tachycardia because the heart rate is more than 100. But the rhythm is regular. The distance between two RR intervals is regular. So this is a case of supraventricular tachycardia or paroxysmal supraventricular tachycardia. The major difference between PSVT and AFib is the rhythm. In the AFib, there is irregular RR interval, but here it is regular RR interval. But both have a absent P wave. So in this way, we can differentiate between AFib and PSVT. Now let's go into the treatment of PSVT. If somebody unstable we say when the systolic blood pressure is less than 90 mmHg. We do not see heart rate or diastolic blood pressure for telling someone is unstable. We say based on this parameter, that is SPP less than 90, then we say the patient is unstable. If somebody comes with this unstable, then you have to immediately do cardioversion. Cardioversion is different from defibrillation. Thus, in this cardioversion, there is synchronized cardioversion where the AED machine automatically syncs with the R wave and gives shock. That is called cardioversion. If the patient is stable, when do you say stable? Because his systolic blood pressure is more than 90 mm of Hg, then you say stable. In such cases, you have to first do certain maneuvers to decrease the heart rate. There are certain maneuvers that magically decrease the heart rate from 300, whatever it is more than 100, to normal heart rate. Such maneuver is called modified Valsalva maneuver. In this modified Valsalva maneuver, you have to give patient a 10 ml syringe and ask him or her to blow into it for 15 seconds. This empty 10 ml syringe you have to give to patient and you ask him or her to blow into it for 15 seconds in sitting position. After 15 seconds, you suddenly make patient lie supine and raise the legs of the patient and hold it for 15 seconds. You can observe the monitor that the heart rate slowly decreases, not slowly, it decreases rapidly and it comes to normal. The other maneuver that is to be tried is carotid massage. Beside trachea, with the 2 or 3 fingers unilaterally. You have to massage the carotid for less than 10 seconds. It should not be done for more than 10 seconds or not to be done bilateral. It is always unilateral and it should be done always less than 10 seconds. If the above two failed, then you can go for medical management, that is giving IV adenosine. IV adenosine, the first dose is 6 mg IV push followed by 20 ml NS flush. Even if it did not bring the heart rate down, then you have to go for 12 mg IV push followed by 20 ml NS flush. This flush is compulsory. Even if it did not bring the heart rate down, then the final 18 mg IV push followed by 20 ml NS flush. This is the treatment for stable PSVT, and in unstable, I told you, cardioversion is to be done. That's it about the PSVT. Thank you.